All right, next up in Learn to Swim is the miscellaneous or MPNST category. Melanoma could be a good fit here in terms of the letter, but really uncommon in kids, and usually those are going to be evident as a skin lesion. I can't think of a single melanoma that I've ever seen that wasn't being diagnosed based on a skin lesion, but diagnosed based on a metastatic deposit. Hepatoblastoma is also something that probably is a talk unto itself, so I won't talk about that too much here. But I'll talk about MPNST. MPNST is going to occur from third decade 20s to the 50s. And the important thing to know is about half the patients that have NF1, about half the patients that have an MPNST also have NF1. Not a very high proportion of patients that have NF1 end up having an MPNST, but almost about half of the patients that have an MPNST turn out to have NF1 once they're tested, neurofibromatosis type 1. So because MPNST is from the peripheral nerve sheath, you're going to find these tumors in places where there's a lot of peripheral nerve sheath. So large nerves in the proximal limbs and the trunk. And the morphology of these tumors can really be small round blue cell to these pretty well differentiated, very fascicular tumors. But the thing that's really going to help you distinguish these from other things is that they're much more pleomorphic. We've talked about a lot of things that have translocations and are very monotonous, but this is relatively pleomorphic compared to things like synovial sarcoma. But synovial sarcoma can have a lot of different degrees of fascicular differentiation, so there can certainly be some overlap with MPNST if you don't have good glandular elements. Immunohistochemically, MPNST is going to pick up neural markers like SOX9 and SOX10. It's going to have a little bit of S100 that hopefully will tell you it's got some dural differentiation. And it's going to have no CD99. That's going to be helpful in distinguishing it from other things. Histologically on the H&E, the thing that's probably most helpful is if you can find the lower grade kind of atypical neurofibroma component to these tumors, that's going to be a great clue to how it arose. So here's something, again, low power, super purple, right? Now as we go higher power, we start to see, as opposed to that storiform pattern we saw in synovial sarcoma where there were short curved fascicles, these tend to be longer, straighter fascicles that are kind of intersecting in almost layers here. A little bit different than that storiform pattern we talked about. And you can see at higher power, these nuclei they're not extremely pleomorphic, but they're not extremely monotonous. Like if you went and looked back at the synovial sarcoma pictures we looked at, those nuclei have what I think of as cookie cutter monotony. In synovial sarcoma and Ewing sarcoma, you can find two nuclei sitting right next to each other that look like identical twins. That's much harder here, and in fact, you can find nuclei sitting next to each other that have a difference in size of about 3 times. So it's subtle. It's not overwhelming pleomorphism, but it's relative to the other things that are driven by fusions. MPNST is relatively more pleomorphic. Now, if you zoom out and look at this at low power, you might find that our really purple area merges with a much more pink area. And what you see in that more pink area is something that looks like an atypical neurofibroma. So this is evidence that this is a peripheral nerve sheath tumor that evolved into MPNST. So about half the patients that have an MPNST are going to turn out to have NF1. These tumors arise associated with large nerves, and hopefully you would find the benign nerve sheath tumor to give you the histologic clue about what it is. I talked about the relative pleomorphism, and it's going to have that staining for neural markers. And you may see some S100. If you stained this slide for S100, my guess is you'd see a lot of it over here and much less of it in the area that's frankly MPNST. All right, so the other M I want to talk about is the molecularly defined class of tumors. And this is kind of a newish section of the talk. So I'm going to talk a little bit about desmoplastic small round cell tumor. We've talked a little bit about EWSR1, the round cell sarcomas with EWSR1 fused to non-ETS partners. Histologically, those are going to look really similar to Ewing sarcoma. You're really going to distinguish those based on the molecular findings. I'm going to talk a little about CIC-rearranged sarcomas as well. Okay, so first up, desmoplastic small round cell tumor. Desmoplastic small round cell tumor is going to present in teens to 30s with a male predominance. And if you ever hear abdominal carcinomatosis in a patient in this age range, desmoplastic small round cell tumor should leap to the top of your differential. It's pretty rare for patients in their teens to 30s to get a carcinoma, and it's especially rare that that would present at a high stage that is disseminated throughout the abdomen that a radiologist or someone might think is carcinomatosis. So when you see that, when you hear that, think about desmoplastic small round cell tumor. Now, much like you might guess from their name, desmoplastic small round cell tumor, these are nests of small round cells, often in desmoplastic stroma. The differential, I think Ewing sarcoma is probably the most important thing to distinguish from desmoplastic small round cell tumor, especially if you end up with a limited biopsy where you just get the small round blue cell component without the desmoplasia, or if you get it invading another tissue type, like invading into the bowel or the liver, that incites some desmoplasia. That could be a really difficult thing to distinguish, especially if you were unfortunate enough to only do FISH for EDBSR1. By immunohistochemistry, desmoplastic small round cell tumors are reliably positive for desmin and keratin. They're also going to have CD99, but like I said before, CD99 is going to be strong and membranous in Ewing sarcoma. It's going to be diffuse. It's not going to do that in other things like desmoplastic small round cell tumor. And when there were an immuno and a carboxy terminal antibody to WT1, that was really helpful because desmoplastic small round cell tumor is only positive for the carboxy terminal antibody. And the characteristic feature here is in genetic findings, genetic studies, is the EDBSR1 WT1 fusion. So here's a really great example of desmoplastic small round cell tumor where you have these nests of poorly differentiated blue cells and a lot of this desmoplastic stroma to go with it. And if you look at this at higher power, this is again that cookie cutter monotony. You got a lot of nuclei that could be identical twins, scant pinkish to clearish cytoplasm. If you just had this alone, I would argue it's fairly difficult to distinguish this from Ewing sarcoma just on H&E. But if you have the other pieces, that makes it much easier. Here's a good look at the high power. Really round to oval, really monotonous. It's a very easy to find nuclei here that are similar size and shape. Again, a clue that this is fusion driven. Desmin is described to have a characteristic dot-like perinuclear reactivity. And so here's a good look, high power. You see this kind of dot-like perinuclear. This is actually desmin that's hung up in the Golgi apparatus of these cells, so it's perinuclear. And pancytic keratin tends to be pretty strong, can be kind of patchy, but you're generally going to find some pancytic keratin in these tumors when you stain them. Now, this is the antibody I love but can't do anymore because nobody sells the N-terminus antibody anymore. But desmoplastic small round cell tumor was really nice to differentiate from the other things with just these two antibodies because only the carboxy terminal antibody is reactive, and that's because that EDBSR1 WT1 fusion only includes the carboxy terminus, so only that terminus is positive by immunohistochemistry, but nobody makes this antibody anymore, unfortunately. All right, so now we'll talk about CIC-rearranged sarcomas. This is another one with a pretty wide age distribution. You can see this in very young children, you can see it in older adults, but the peak is going to be in the 20s and 30s. This is small round blue cell tumors, and to me, I think of this as a tumor that has mixed cytology that overlaps both Ewing sarcoma and alveolar rhabdomyosarcoma, not even alveolar, but any rhabdomyosarcoma, and I'll show you that in a second. So if you see a tumor that you see features that kind of look like both of those things, you might want to think about this. The other thing that's pretty striking is these tend to have this kind of serpiginous necrosis throughout the nest. And I'll show you that in just a second. So the differential, again, because it's monotonous, the differential is from other things that are monotonous, like like Ewing sarcoma, desmoplastic small round cell tumor, synovial sarcoma, and rhabdomyosarcoma. My favorite immunohistochemical stain for the CIC-rearranged sarcomas is DUX4. That's because CIC is most often partnered with DUX4. About 95% of these tumors are going to have a CIC DUX4 fusion. And the DUX4 antibody is going to be really sensitive and really specific for tumors that have a DUX4 fusion. CD99 is going to be patchy in these tumors, and there can be variable WT1 reactivity, particularly in the pediatric cases. So here's an H&E section, and you can see it's got some pretty broad, kind of fibrous, maybe even almost desmoplastic looking spaces. But look at this river of necrosis that's running through the middle of these nests. So that serpiginous, that winding necrosis, that's a pretty good clue. I've seen people see that on frozen section and think, gosh, this could be a CIC-rearranged sarcoma, and turn out to be right. So histologically at high power, again, pretty monotonous, maybe a little more pleomorphism than your average Ewing sarcoma, but I think this is pretty similar to Ewing sarcoma. Round, oval, pretty monotonous nuclei. Now I'll point out, When I talked about Ewing sarcoma, I said that population of small dark angular cells at the edges of the nest was really helpful. You'll notice that's not here. So this area does have a pretty Ewing-like feature. But here's an area where you see that variation in cellularity. When we talked about rhabdomyosarcoma, we talked about embryonal rhabdomyosarcoma having variation in nuclear density and myxoid stroma, and here's that as well. You have this myxoid stroma, variable cellularity, so you kind of have features of Ewing sarcoma and rhabdomyosarcoma, and in fact, in this example, all these pictures are from the same tumor, by the way. And right here, here's some really rhabdoid cells with eccentric cytoplasm that's all on one side of the nucleus. So when you see that mix of histologic features, that's a good time to think about the CIC-rearranged sarcomas. CD99 can be pretty patchy. Here's some cells that are pretty nicely stained, but you see most cells are not really picking up CD99, except maybe some Golgi staining. And here's that DUX4 immunohistochemistry, like I mentioned, really, really nice nuclear marker. All right, so we've gotten through learn to swim. We've gotten through all these. We talked about at least some of these for each of these letters in the mnemonic. We talked about how it's important to gather all the clues you can get. Patient age and location are critical. Laboratory data is really helpful. And then you really got to look at the histology to figure out how to pick your confirmatory tests. I'll share all these summary slides of the clinical and pathologic features of these tumors. I'll put all this on social media in addition to sharing this recording. This should be a nice wall hanger for you to kind of look back and think about all the things that we talked about. So